Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. J. Calvert, and I'm sitting here on a Wednesday lunchtime, as a matter of fact, with Dr. Rovelo, taking a break from our patients for a moment to knock out a couple podcasts.
That's right, we gotta squeeze it in where we can.
That's right. Today we're going to be talking about who is not a candidate for a Mastopexy.
Who is not a candidate?
It's like the Borat not joke. Who's not a candidate?
Because this comes up so frequently.
This patient is not a candidate for a Mastopexy.
I'm gonna record you saying that and just play it to my patients. I'm like,
You are a candidate for Mastopexy. Not. You can use that one?
yes, that's a good
You
one
want me to
too.
give you a few more? No. Yeah,
serious.
it does come up.
It does come up.
Why?
And because I get frustrated. I want my post-ops to look amazing, and I want my breasts that I do to look beautiful, and I get so sad. Like, I literally get sad. I get sad when I do mastopexies on patients and their breasts don't look beautiful. And I get frustrated because there are patients that are great candidates for mastopexies and there are patients that are not. And when I do a mastopexy on a patient that's not a great candidate, I don't get a great result, and that makes me sad.
I don't want you to be sad.
I know.
Your patients don't want you to be sad. They want to do well for you. They want you to be proud. I know they do. They want you.
It's not really about them. It's about me. Joking, totally joking. But
No, I know. I get it.
But in the sense that it's true, you do want your plastic surgeon to be happy because that means that they've done a good job for you.
Well, let's start at the beginning then. Mastopexy is an operation for lifting the breast and putting
I'm
nipple
going to stop
areola.
you right there. It is not a breast lift.
It's a nipple areolar complex lift. With for me, it's moving the breast up the chest wall. I do some stuff with that.
Yeah, you can. But I think that's the first distinction that has to be made, is that it's not really a breast lift in
Right.
the sense that many patients want it to be.
They do. They do. They want the breast
They
to
come
go
in
up the
and
chest
they take
wall.
their hands and they take it around their breast and they push it all the way up and they say, "This is what I want. I want this."
You'll need an anti-gravity gun because that's not happening.
It's not happening.
No. But you can make the breast look beautiful.
Yes.
So
In the right patient.
Okay, so back to that. The ways that we can lift the nipple areolar complex and make the breast look more youthful and less droopy and saggy and sad is through a periareolar mastopexy with a cut around the nipple areolar complex, which can lift the nipple areolar complex a bit.
A few centimeters.
Yeah, not a lot. You can do a vertical where you do a periareolar incision with a vertical component down the front of the breast, underneath, going from the areolar complex to the inframammary fold,
Like a lollipop.
where the breast meets the chest wall, like a lollipop. Or you can do a full-on anchor scar with around the areola, down in front, and then in the inframammary fold. That is the most gold standard. You're gonna get a lift of the nipple areolar complex with that approach every time. Periareolars are very unsatisfying to me, but a lot of people want them because they don't need a whole lot of lifting and they don't want the scar down the front of the breast.
And we are going to segue into a little bit of implant talk here. My initial comment is that I find that mastopexy technique works best if you're putting in an implant as well.
Hands
On its
down.
own,
It's
you're
the
not going to
worst.
get a whole lot out of it. Yeah, like
It's
I'm
the
not a lot.
worst.
And you got to be careful, because if you come in and you demand and say, "I only want the scars around my breast," and your plastic surgeon is telling you you need more, but you insist that you only want them around your nipple, you will end up with a breast that might have a higher nipple areolar complex, but that is more flat.
It does flatten the breast.
The higher you try and go and the more skin you try and take out through just the little incision around the nipple areolar complex, the flatter the breast gets. It's
Right.
just geometry.
And that's why you need the vertical component, because you're bringing the sides of the breast in, which pushes the tissue out, and you get more of a coning of the breast,
Right.
as opposed to a flattening of the breast. I make that explanation probably 3 times a week. I do. And they're just like, I just really don't want the vertical scar. Well, I get that, but if you want, you got to decide pretty shape a vertical scar.
Vertical scar. And here's the thing, the more skin you try and take out, the bigger of a lift you do with just a periareolar approach, the worse your scars are going to look. Because you're going to have more tension on that wound, you're going to have more rippling around the scar, and you're going to have a thicker, uglier scar.
100%. And this discussion is forgotten by all patients having a periareolar or mastopexy.
Yes.
Well, I told you that was kind of the deal. That's the trade-off. Oh, but I would have never done this if you told me that. Well, I did tell you it, and we did do it. So here we are now. We can't undo it because we've done it, and we did have that discussion.
Right.
Yet the retention is not great about that discussion because they don't want to hear it. They don't want to hear that the periareolar isn't the godsend that they were looking for.
It's really not.
It's not.
The lollipop incision is sort of my go-to. I think it does. I think
works.
it's a great technique. It is. It does the job. You know, every once in a while I do have to convert to the anchor scar and large breasts or what have you. But even then, it's not that big a deal because usually if you need an anchor scar, it's because you have large breasts, a lot of skin, and that incision in the IMF fold is going to be hidden by the rest of your breast that's going to hang over it.
So our first patient who is not a candidate for a mastopexy is somebody that needs a big lift who doesn't want a vertical scar. So if you need a big lift but you don't want the scar, then you are not a candidate for mastopexy.
Not at all. The scars are part of the deal.
Part of the deal.
It's part of the deal. The other candidate that's out there who is not a candidate.
Not a candidate. I'm just going to keep going with Borat on this one. It's too funny.
Is the patient that has what we call pseudotosis.
Yes.
So pseudotosis, tosis is the fancy word we use for when the nipple areolar complex is sitting lower than the fold in a lower, droopier position than it should.
Ptosis is basically descent of the nipple areolar complex to a position lower than it should be,
Lower
ideally.
than it should be. And that can be from many reasons: childbirth, breastfeeding, that's just how your breasts are, age, gravity, etc. Pseudotosis means that it's like fake tosis. So the nipple areolar complex is actually in the appropriate position.
Correct.
But it is the breast itself that is hanging lower than the fold.
Right.
And so it's kind of visually deceiving because the nipple actually looks like it's in the middle of the breast because there's something that's hanging below it. But that is not something that can be fixed with a mastopexy because the nipple areolar complex is already in the proper position, more or less. What you want when you come in and say, my breasts are just sad or they're droopy or they're hanging lower, is you want to try and get that breast tissue that's hanging up onto the chest wall. And the only way to do that is to put an implant in, really.
Yeah, I mean,
Depending on your breast size, but yeah.
I think trying to fix pseudotosis is really tricky.
Yeah.
Because you're going to wind up doing a wise pattern,
You're going to get a scar on the breast.
You're
going to get, at the very minimum, a vertical scar on the breast to bring in that extra tissue that's below the fold.
Yeah, pseudotosis is tricky because people think that there's an operation that can be done pretty easily to move the gland, but you can't. You put in an implant, that's about all you got.
That's about all you can do.
So what other patients are not your favorite candidates?
The ones that come in and tell me they want a breast lift. They want to have the perky breasts they had when they were 20 years old, and they do that move where they put their hand at the bottom of the breast and they push it up and they say, this is what I want. I want a breast lift. I can't really do that with just a mastopexy. The mastopexy is designed to move the nipple areolar complex up on the breast, up on the chest wall. You get a little bit of lift with the gland and the breast tissue as well, but you are not going to get superior pole fullness. You're not going to get breast up top, up high like you want with a breast lift. It's an unfortunate name. It's not a breast lift. It's a nipple areolar complex lift. And so if that is your goal, then you're looking at an implant.
Yeah, I mean the implant, and do you remember, I don't know if this may be before your time, but there was a time where people did not want to do mastopexies and OGs together, putting in the implant at the same time. They would stage them, they'd do the lift first, then come back and put the implant in.
Surgeon beware.
Yeah, there was, I remember a very prominent surgeon standing on the podium saying, if you do these things together, it's malpractice. And I was like, no, it's not. I was like, you can't say that. Like, who says things like that?
Well, the pendulum has definitely swung. I would say it's pretty commonplace and routine.
It's totally
To
routine.
now do the Mastopexy augmentation, because who wants to have 2 surgeries, you know?
No, and you can make it work
You
the
can
way
make it
with
work.
like there's all kinds of approaches, and we do these all the time.
Yeah.
But I remember that was probably in 2002 or 3 that it was a very prominent surgeon who is in this town, Los Angeles of ours, and he stood up at the LA Society and said, like, that's malpractice if you do them together. And I stood up, and of course I was like, I 1,000% disagree, because we do it all the time. But on top of it, like, who are you to decide that?
It's malpractice. I'm pretty sure that surgeon is now doing Mastopexy augmentations.
Constantly.
All the time.
Constantly, he does tons of them. It was a very prominent breast surgeon. So, but the thing is that not only is it better in terms of result, but I think if you do them together, then you can take advantage of the implant with the lift, with the Mastopexy, so that you're using the implant's power to shape the breast to also help your Mastopexy look better.
1,000% agree. You're now shaping the skin and the position of the nipple around your implant.
Yeah.
So it's, no, I agree. But we digress, because we are supposed to be talking about Mastopexy.
It was not.
It was not.
Who else is not a candidate?
Someone else. So just to recap, someone who wants to come in and get superior pull fullness, and that's you're not a candidate for Mastopexy. Not a candidate.
No, if you want to have, like, you know, and this is just like our last podcast about fat grafting to the breast. Like, it doesn't look like an implant. Like, if you just get a lift, if you just do a standard Mastopexy, you're not going to get superior pole fullness.
That's not what it's designed.
It doesn't do that. I mean, you could add some fat grafting or something like that, which I have done. I've done Mastopexy with fat grafting.
That is good.
It helps.
But
it's not. It doesn't look like an implant.
No.
And that's the thing, is people like the way implants look. They say, well, I want to look natural, and they bring in pictures of all these girls with implants. I'm like, okay, so you want to look naturally augmented.
Right.
You don't want to look natural, because these aren't natural
These are
breasts.
natural.
I'll show you some natural breasts, and you will not want those.
No.
You know, you want, if they're looking for a very beautiful augmented look, that's great, but that's not what a natural breast looks like.
And it can be small. The implant can be small. It doesn't
Totally.
have to be an augmented, fake-looking breast. But if that's the look you want, you need an implant. My next patient that is not a candidate for a Mastopexy is the small-breasted woman who may have breastfed, or for whatever reason has had involution of her breast tissue, and she has extra skin, descent of the nipple, and very little breast tissue.
Yeah.
This is not a good candidate for a Mastopexy. It's not. It's just not.
Because it's gonna look like
It's gonna look so bad. It's gonna look bad.
it's gonna look like things happened to the breast.
To the breast that should never happen to a breast.
I think Steve Martin made a joke about something like that, where he said, I was thinking about this the other day while I was sitting at home doing terrible things to my dog with a fork. I was like,
What?
so I was thinking of, like, what would it look like to have this Mastopexy on these? I mean, they just look terrible.
It's so bad. It's not good. I guess we should, say who's a good candidate for a Mastopexy. Typically, it's someone that has a decent amount of breast tissue already.
This is Mastopexy alone.
Alone.
No implant.
No implant. Has a decent amount of breast tissue, has descent of the nipple areolar complex. Those patients do fine. They do great. They can have their natural, beautiful breast with some scars on it.
Sure.
But they will have probably the look that they're going for. A fuller, more lifted, natural looking breast. Anyone else other than that probably needs an implant.
Yeah.
Or just won't have the look that they are going for.
Well, and that's the thing, is we don't want to do stuff that's not going to make them look good. You know, we have
Breaks
standards. And I don't want you to be sad about the work that you do, and I don't want to be sad either, actually. So, I think in order to have great looking breasts, you really have to go with the recommendation of the surgeon. The massive weight loss patient.
Oh yeah.
That Mastopexy is a whole different animal. I mean, there was also a time where they said, oh, you shouldn't use an implant in these patients. And
You have to.
You have to, and I actually published a paper about that, about how to use a lateral breast flap to control your implant. And it is hard because it's like the implant can go all over the place. You know, the skin envelope of the whole person is too big, and so you don't have a whole lot of control unless you do some things to make that happen. That's why I use that lateral breast flap to kind of work with the pec to keep the implant in position. And in fact, I just saw a patient back who I did that on 14 years ago, and she came in for a facelift, and her breasts are like they're like gold. They look amazing.
That's great.
And they had the lateral breast flap. She's in the paper, as a matter of fact, one of the patients, and they've held up incredibly well, but it's also very hard. So
it's hard. There's a lot of skin. There's a lot of skin on the sides. It's one of the main problems, and there's just overall lack of volume, lack of tightness of the skin. Even once you've removed the excess, it's just not tight. And so without
the skin can be very elastic.
It's very inelastic.
Very elastic.
Elastic, yeah. It's just very stretchy. And so without an implant under there, kind of filling out that skin envelope, it can be an unsatisfactory result.
Okay, so we kind of nailed all the not candidates, and we got the candidates.
And the candidates. That
Okay.
one specific person out there.
There's one person.
That one person.
And they are pretty rare.
Yeah.
Yeah, I mean, I don't do many mastopexies alone. I
don't either.
Yeah, mostly put an implant in or do fat grafting or something, or both.
Yeah, I generally, even in the ones that are good candidates, I typically add fat as well, just because I can. I'm there.
Yeah.
You know.
Well, cool. Well, it's another round of the Beverly Hills Plastic Surgery podcast coming to you from the 90210.